So welcome to the Midwest Tribal Echo. We're going to start by introducing the members of the Echo team. If we could just start with you, Michelle.
Hi, I'm Michelle Corcoran. I'm the nurse manager for the MAT program here at NACC.
I'm also going to ask our speaker, Simone, to introduce herself because she is part of the NACC team.
Hi, I'm Simone Megas-Harmason. I'm the NACC Red Lake IOP program manager.
Great. Tina?
Hi, my name is Tina Monnier. I am the harm reduction program supervisor here at NACC.
Lindsay?
Hi, I'm Lindsay King-Cooney. I'm the community and tribal engagement specialist here at NACC.
And actually, Dr. Gale, if you wouldn't mind introducing yourself.
Sure, I'm Dr. Gail Mason. I am the Director of Behavioral Health here at NACC.
Thank you. And I'm Kari Ravi. I'm a physician and I do MAT here at NACC. Okay, we're gonna go ahead and start with the slides. Great. So again, welcome to the Midwest Tribal Echo. We have a presentation today on de-escalation and crisis intervention tactics with Simone Megas-Harmason. Next slide. Okay, and then we always just start with just to briefly to tell you a little bit about NACC. We're a federally qualified health center. We were established in 2003. We exist on Franklin Avenue, right in the center of the South Minneapolis urban indigenous community. We provide primary care, we provide Suboxone or MAT. We do infectious disease intervention and treatment, social service supports. We have a dental clinic, a behavioral clinic, an intensive outpatient treatment program. We provide elder care and traditional healing services, health promotion and maintenance programs, as well as harm reduction services. Next slide, please. And then I'm going to turn it over to Lindsay.
Some session guidelines, so no protected health information as always. We ask if you're not speaking, if you could mute yourself. You're always welcome to eat your lunch during the session, of course. And then we invite, if you have any questions or comments, please use the chat. So our next session is December 7th with a yet to be determined speaker. And then December 21st is a holiday week, so we will not be having a session that week. This is just a list of a few other echoes that we recommend, echoes that cover topics like harm reduction services and OUD. We have Indian Country Echo, Stratus Health, and Hennepin Healthcare. So if you'd like any more information on those, just let me know in the chat. And then we also offer continuing education credits for those who are eligible. We just ask that you complete the survey, which I'll send out after this session to receive that credit. And then finally, case presentations, we always encourage if anyone has one to share, please do so. You can always email me or contact in the chat. It's a great way for us all to learn from each other's experiences. And then with that, I will stop sharing and hand it over to Simone.
Hi, everybody. Let me see if I can pull up my slides here. All right. Can you guys see it?
Not yet. Is she co-host?
All right, hold on a second.
She's not co-host.
Let me know when you.
Just give us a minute, Simone. We'll get
Okay,
you.
I just want to make sure it's not on my end.
There you go. You're there now.
You got it.
All right, everybody see my slides?
Nope.
What am I doing?
Are you doing share screen at the bottom?
Let me see here. All right. Now?
Yeah.
There we go.
We see that,
Hey.
and then you just have to start slideshow. Yeah.
Sorry, it's been a while.
Yeah, I know. I've been there.
Here's my fancy slideshow. This is as fancy as I'm getting.
Great.
So today we're going to talk about de-escalation and crisis intervention tactics. See. So I'm Simone Megas-Harmason. Just to give you a little bit of my background, I have police training. I have worked in hospital security, corrections, and now work in chemical health field. So my master's is in forensic psychology. So I've learned a lot in all these different systems that I've worked in, and I wanted to share them with you guys. So first rules I want to go over in terms of crisis intervention and de-escalation. Really, it's about checking your ego at the door. It's a really difficult skill, and it takes time to really work on fine-tuning that skill and understanding kind of where your mind space is and where your own, kind of fight or flight reactions in situations. Having a good knowledge of that is really important, because it's really not about commanding or necessarily controlling verbally the situation. And I think that's a natural reaction. It's about assessing and using communication skills to support reducing risk. So it's a constant learning in different situations. And the goal is also to walk into a situation with objective motives. So you're looking, you're assessing, you're listening, and not judging the situation when you have the opportunity to. So that's really difficult to get out of that emotional crisis cycle. The rule is also to assess and reassess of behaviors, actions, and needed reactions. So like I said, pulling yourself out of the actual emotional responses that you may have normally and naturally as a human being when you're approaching situations or dealing with situations. And then keeping in mind how you can better control the environment. So it's not just that initial contact of anyone who's in crisis that you're looking to support, but you're also managing or trying to control the environment from overstimulation that could cause, increase or escalation. The goal of crisis intervention is really to return control to the individual in crisis. So that person who is actively in crisis doesn't feel good, right? They're struggling, they're having a difficult time. There's a lot of uncomfortable emotions that they're experiencing. So our goal is to support and, through skills and tactics to help that person gain control of their emotions and their behaviors. So that's a huge one. It's not us controlling them, right? We're working with them as a partner for them to gain control of their own emotions and come back to a baseline. But we're also, the goal is to gain compliance. So whatever it is that we are needing from them is also a focal point of the goal, and eliminating any safety risk. So as we're assessing and reassessing, we're also thinking about not only that contact with that person, but any potential safety risks as we're working with that person in de-escalating. And then I think this one's a huge one that we don't think about because we're always thinking about the actual crisis, but a majority of the situations that we encounter with folks who are in emotional crisis, having an emotional crisis, when they are able to de-escalate, a lot of folks will de-escalate if we're communicating effectively. We'll see that, and I'll touch on that as well. But the follow-up, also helping to build that rapport, thinking about how, how patients will seek help in future situations when they're experiencing the crisis that they're going through at that time. And then just to touch on what an emotional crisis is. So an emotional crisis is more acute. So it's an emotional distress experienced by an individual that affects the person's ability to regulate emotions and influences their behaviors. So that's the most common that you may see people coming in the door. It might be more of acute situations. I also added like SPMI, so any serious and persistent mental illness. which would include like bipolar, major depression, schizophrenia. Those folks that we encounter at most places are in hospital settings, programs, things of that nature. It's more emotional disturbances. So they are struggling kind of on an ongoing basis to, manage their emotions and regulate. Some mental health condition stats. So an estimated 1 in 5 adults have a mental health condition, and people suffering from an SPMI have a 10 to 25 year reduction in life expectancy, and understanding the severity has a strong correlation to comorbidity. So meets the criteria of 2 or more disorders. So it could be a mental health, substance use, things of that nature. And then a diagnosis. Now I'm touching on schizophrenia and bipolar. I'm bringing that up because I feel like those are the folks that are the most vulnerable when we talk about like consistently in systems and who we're encountering, who may need support with like de-escalation. There are also folks that you may see more, I call it bizarre behaviors, because they may look, they're exhibiting behaviors that we don't see daily. So, if people are responding to internal stimuli, or maybe they're escalating quickly and having a hard time regulating, you're going to see different aspects of that. And it doesn't necessarily mean that there's a risk factor in it. So it doesn't increase the potential of any violence. So I think a lot of times people will equate like bizarre behaviors, things that are outside of the norm of what you may see day to day, with equating to risk of violence. So that's not true. So mental health and any drug or alcohol use could increase potential of violence. So I just want to also put that out there as a potential factor, not necessarily anything outside of that, just something to consider. And then here's what I want you to take into consideration when you encounter a person that's experiencing an emotional crisis. The experiences that they carry with them. So people that suffer with chronic mental health conditions are more likely to have a history of hospitalizations and potential future episodes of inpatient care. There's systemic traumatic experiences through those systems as they're needing care, seeking care. Persons with SPMI make up a large percentage of the homeless population, and many are undiagnosed, right? Homeless are more likely to be victims of violence. So I want to touch on that because those are a lot of our folks who may be coming into clinics seeking care, needing the most support. So they struggle with maintaining employment. Their experience symptoms have isolated them from family and social supports, and they tend to rotate between criminal justice system, treatment programs, hospitals. It's kind of that revolving door. So with my experience in different, in more legal criminal justice and hospital settings, as well as treatment, that was really like it really set off a light bulb in really understanding, the journey to many folks' experiences through these systems as they're trying to seek care or are in need of acute care. And then why is this important? Like I said, they tend to rotate through those systems, right? They have those touches. And then as they're rotating through the systems or seeking care at the same systems, they're labeled as the problem. So those experiences create a distrust and defensiveness when in those systems of care. So a lot of times, I don't know if you've looked over, discharge summaries from hospitals, for example, you'll see, malingering is a common word used for folks who are in those care systems. So thinking about, how that can be stigmatizing to those folks who are experiencing these contacts with this care system or within the care system. And many folks don't really understand their care options. They have long-term needs that aren't addressed. Like I said, they utilize acute services, and they tend to lose their voice in care decisions as they're throughout their life as they're touching different systems. They're coming into clinics and programs with a history of those stigmatizing experiences. And our goal is to make sure we're partnering with patients to increase engagement and care decisions. So some behavioral indicators of crisis is impulsive behaviors such as anger. You'll see this, right? Signs of self-injury, depressed, irritable, and anxious, general inability to regulate emotions, and see a constant change in emotions during interactions. Behavioral cycles that we see, emotional vulnerability. So people who are walking in to get care or are in our care, what are some of those indicators? Are they react to low levels of stress, they have difficulty coping, may blame others for unrealistic expectations. You'll hear that, you may see that. Invalidating environment, tendency to show self-invalidation. So a lot of shame and anger with themselves is also an indicator of crisis. Frequent traumatic environmental events in a state of like this unrelenting crisis. So relating to dysfunctional like lifestyle, so risk behaviors, bad relationships, just, you know, a lot of chaos within life and that coming in as well. Extreme emotional reactions, so there's a delay in return to baseline. They're experiencing one crisis after another, and it's kind of that downward spiral. Some you may see active passivity. They want others to solve their problem for them. They're not active participants in the problem solving of their own experienced problems. They give the impression that they are competent in response to the environment, but the skills don't materialize across the situation. So they may say, yep, I know I need to do that. I can do that. And, you know, that's a verbal, but you're not necessarily seeing them either able or in a position because of their crisis, emotional crisis, to take those steps to address the situation. And then patterns of self-mutilation as a means of coping. So suicide attempts and suicidal statements. Verbal indicators of crisis is I'm having a hard time. These are some of the statements you might hear. I wish I were dead. I can't take it anymore. I had a triggering experience. The use of sarcasm, bitterness, which later results in guilt or shame, yelling, cursing, blaming, or non-responsive. So lack of control of behaviors. And now that we've identified a person presenting, person in crisis presents like now we're going to touch on like next steps. Really assess risk in relation to behaviors. So what behaviors do you see? Answering this question will give us information as to where the person in crisis is at in that escalation cycle. And we'll also touch on what the escalation cycle is. Ta-da! Like my graphics. All right, the escalation cycle is really where people are at and looking at what you're seeing, what you're hearing, and comparing it to this escalation cycle. So you really, when you're able to identify where a person's at when they're coming in crisis, it helps you to match that intervention and also to reduce the risk, potential risk involved. So people could come in calm, they're triggered, and we'll go on to this next one. When they're triggered, you'll see a quick change from calm to agitation. So person may, some things you'll see is they'll fold their arms, they'll turn away or shut down, or verbally express their agitation. The trigger phase is starting to send a person into the physical reaction of fight or flight. Acknowledge and identify that change. Agitation, when they hit that agitation stage, it's a person becoming more verbally confrontational. They start speaking faster or excessively, become more fidgety, may start to make threatening comments. You're not only hearing the expression of agitation, but now you're seeing it manifest physically in behavior. So And I'm such a, like, I act things out. So I hope I have enough space if I, but they'll go from sitting to standing. So they may start verbalizing that they're upset, but then it starts to escalate, right? Now they're starting to stand or they're starting to pace. So that verbal plus physical is an indicator that there's that acceleration, right? They're accelerating. During that process, you're going to be assessing the environmental risks of those behaviors. So, if you're someone responding to it, you're that first point of contact, you're going to approach that situation with caution, listening and watching before actually interacting. Where is you want to know, where is the incident occurring? Being aware of your environmental factors that could potentially become a safety risk, physical safety risk. So is it in a small space? Making sure that you know where the escape routes are in that space, which also means being mindful that you are not blocking that person from an escape route, because if that person is accelerating or, during the interactions starts to accelerate from trigger to agitation, then you're going to want to stay out of the way because it's that fight or flight. So you will want to move so that person doesn't feel trapped as well. So being very aware of how you're positioned, if you can, creating barriers between yourself and that person in crisis, space, just because you don't know at times, especially if it's someone that you're unfamiliar with coming into the clinic or seeking care, you want to make sure that they don't feel threatened. And you also want to make sure that you are at a safe distance, if any, to be able to react. So through my police training, they say, a minimum of 6 feet. Now with COVID, that's pretty normal. People being 6 feet apart, but realistically, if someone had a weapon on them, it's 21 feet for you to react in a way to get out of the way and not get injured. So just thinking about, if that patient could have a weapon on them. We have a lot of people who come into clinic who are homeless, who carry weapons for their own protection. So just being mindful of it. And also where their hands are at and where your hands are at, because part of it is being very open. So your positioning is, you're wanting to stay open, you're wanting to also send that message. And then also, what could someone use as a weapon in that area, right? Because when you're frustrated, you're upset, people can throw things, people can kick things. So thinking about kind of the environmental ways that we can safeguard or clear or reduce that risk. And then communication styles to avoid. Please don't tell them to stop thinking about the past or use language that invalidates how someone feels, or give like pep talks about moving on with their life, or say things that also dramatize their pain or show shock at what they say. So they are also reading you, right? So you're going to want to be very mindful of your language that you're using, and also your reactions. And then don't cut them off while they're speaking, or say, I know what you mean, I know how you feel, or give commands or use authoritative language. So the commands piece and authoritative language, like I said, we're looking also at, where we're in that range of trigger to agitation, and working on that de-escalation. Like, obviously, if it becomes a threat, then we have to be very clear about what we need from that person. So it may sound more authoritative, but be very cautious of sharing personal stories as well that attempt to relate to the person in crisis, because it can be unproductive. It can cycle right into or pull you into that cycle of crisis. And then also making statements like calm down, or that's not appropriate, everything's going to be okay, or what's your problem, or you need to. So that's another command. Avoid arguing and any confrontation. So individuals experiencing a mental health crisis tend to obsess, worry, revisit what is They have emotional pain they can't address or relieve. So maintain your boundaries. Don't feed into that rapid emotional changes that that individual is displaying in that crisis. Also avoid whispering, especially with folks who are paranoid. Whispering can be really difficult because it creates a lot of distrust. So being very mindful of not whispering. Threats, obviously, choose your words carefully, but to continue to be transparent. Don't make promises you can't keep. And communication dues are I hear what you're saying and stating your intentions. Let me make sure I understand what you're saying, reflect back, create options of what you can do. Here's what I can do versus, you know, what you can't do, focusing on that. Use the word we to create rapport with the patient. They are a part of the process of de-escalation and problem solving. After listening, make the statement, let me see what I can do for you. So that's also to really pull back from that promise making. Can you, will you, you know, really creating it that they're doing you a favor, right? That helps them to buy in and be a part of that process. Open-ended questions, what brings you here, can help you on the front end for sure, figure out what is it that that person needs. And then I have two different models that I wanted to touch on. The SET model, which is support, show support by addressing the person's demands. Use phrases like, I want to help, I want to try to help you, please slow down and help me better understand whatever that issue is that they're experiencing that's causing them the crisis that you need. The goal is to let the patient know that you're working with them, partnering to meet their needs. That doesn't mean giving into what they want. And when I say that, we work within the parameters of what we can offer within the clinic setting. You know, there's what they may have certain expectations, but we're working with them to negotiate and meet those needs within the parameters of our own clinic rules, regulations, services, processes. Empathy, so true awareness and validation of the feelings. I understand that this is frustrating for you. Identify and the demonstrated feelings you're seeing and put them into words. And then truth, objective and focuses on the it, not the subjective experience. Difficult people in crisis may ask for the impossible or present with the no-win situations. Use phrases like, unfortunately, I'm unable to whatever it is they're requesting or wanting, but I can, and you create options. So you're partnering with the patient in problem solving. May mean taking extra time to explain the process to them. And then I also threw in the Dear Man model for all my mental health folks. So the Dear Man model is Marsha Linehan. She's a clinical psychologist in dialectical behavioral therapy. So this is used in the mental health world, and it's wonderful in crisis de-escalation as well. And I feel like there's so many tools online on how to practice this. So even utilizing this within your own teams that you work with to learn to just automatically effectively communicate. It really helps with folks regulating their emotions and also de-escalating. So the Dear Man model is, describe the situation in a simple way using facts, right? So whatever it is leading to their request, you're going to describe the situation and what that request is. And then you're going to express how you're feeling. So using I statements, where you're coming from. Allow the patient to take accountability, and it really prevents them from getting defensive. So it's a clear request of what you need from them. So it's setting up those clear expectations. Sorry, I jumped. That's the assert, is the expectations. So this is when you ask what you would like from that person in a clear manner. So they're requesting, you're explaining the facts, you're expressing the I's of what you're trying to do to support that. Then you're also asserting the clear expectations of what you need from them, and then reinforcing why they should grant that request. And then the man is how to do it, being mindful, try not to become distracted by other topics. Instead, keep your focus on the conversation you're having right now. Appear confident. So make sure that you are present in that conversation, that you are being very aware of your body language in that conversation. And also when we say being confident, use language that isn't maybe, I don't know, you want to make sure that they understand what you can and can't do, and then negotiating. So you don't need to go in with demands from that person. Instead, you're going to be open to compromise to fix the situation. Like I said, negotiating within the parameters that you're able to. So really understanding those boundaries and what you're able to support and serve and do in those situations is also important. And then diffusion strategies. So be aware of your body language. Like I said, avoid sudden movements. Keep both hands visible. I'm big on keeping my hands up here. And this is just a way for me to, as I'm talking to people, to number one, they see my hands, I'm being open, right? And I also can react to defend myself, right? If I'm having my hands up a little bit higher, usually above your waist, right? And then you're going to want to lower your voice. You want to keep a calm tone. You want to speak slowly. Calm the person and assure he is being heard before trying to solve the problem. So you're listening, you're keeping a calm tone, you're watching, you're listening, you're evaluating, and then eliminate any unnecessary environmental stimuli as much as possible. If that means moving still to a bigger space where there's less foot traffic and they're willing to do that, then you're gonna want to do that, because that can be very confusing and agitate people more if they can't hear you, or there's just a lot of other things going on in that environment. And then take time to listen, give clear, brief, assertive instructions, like what you need from them. Can you please, I need this from you. Can you do that? Explain your purpose or intention. Check that you're understood. Keep patient focused on the problem they're experiencing now. So you want to keep them in the now, because you're going to address the issue that they're expressing now, and then negotiate options. Move towards a safer place. If a person is displaying psychotic behaviors, a huge part of that is not playing into those delusions or hallucinations. So if they're seeing or hearing things, you're not agreeing that you're seeing and hearing them as well. Give the individual in crisis a chance to process. So that's that pace when you're speaking as well. The appearance of authority may increase behaviors. So being mindful of how many people are responding. Also your mannerisms. Use facts and not reasoning as a tool. Validating and supporting where someone is at is not the same as agreeing with them. We're assessing and reassessing the situation throughout the interaction. You're also being assessed. So I want you to consider that and think about that. Being mindful of your own, behaviors, tone, distance with folks, how far away you are. So you are being assessed as well by the individual in crisis. Your reactions are being assessed. And if you appear judgmental or rejecting, this can create more anger and defensiveness. Okay, here's what you'll see if the de-escalation skills that you're implementing in the situation are working. The person will start to mimic your calming demeanor, right? Even physically. The person will engage in further discussions of options. So if you throw out those options and they are willing to have conversations about it, that's a good sign. They're de-escalating. A de-escalation of behaviors or verbal agitation. So they'll move from that standing to sitting. The person will respond to what you're asking them to do. So that's when you know that they're de-escalating. If if a person hasn't responded to that de-escalation. Now, some people may peak and it's just their peak is verbal, right? They're upset, they're verbal, but they're still doing the things you're asking them to do. You need to leave, and they walk out the door. That might be it, you know, but we're looking at, you know, if that person continues to escalate where it's threatening, physical, violent, they're closing in terms of space, invading space, throwing things, kicking things of that nature, that's an escalation. Now, if it becomes threatening or violent, then you would want to make sure that you're calling 911, you're calling emergency, because now you've crossed, you know, that threshold of there's no way of de-escalation in terms of the risk of violence to, you know, the environment and keeping people safe. So if you need to call 911, you're going to want to continue to observe and make sure you're keeping others safe, removing people from that space. And then you're also going to, you know, once EMS has arrived or police have arrived, the response team, you would want to, and it could be crisis response, whoever arrives, you're going to want to advocate for that person in crisis. So any information that you have that could potentially help them with getting connected to services that fit or meet their needs, anything that they've shared with you or that you've heard, you're going to want to relay that as well to EMS. And then important takeaways is really learning to identify levels of crisis in the escalation cycle, where people are at, and work on implementing appropriate interventions to reduce those risks. So the more that you practice, like the Dear Man, that communication piece, really looking at and assessing, you know, what you're trying. Now, sometimes it'll work, sometimes it won't. As you're learning and as you're developing skills, and not everybody's the same, you're really, a big piece of it is understanding where they're at in that escalation cycle, right? So if the intervention is working, you're going to reduce that risk. If it's not working, you're going to want to disengage, and it's okay to, you know, tap out someone else to jump in, have those conversations, depending, you know, your goal is to not escalate, right? So whatever it looks like as you're watching behaviors, considering where they're at in that escalation cycle. And then of course, prepare according to the level of behavioral crisis and continue to assess and reassess. So that's constant. If the person in crisis de-escalates to the point of like further exploring supportive options, follow through by offering either mental health, if that's an option that they, you know, a cope, or, you know, voluntary, just exploring that with them to support them, because there is a lot of shame, and people who have those, especially those acute periods of escalation, right, that emotional crisis, they do tend to come back and feel bad about it and feel bad about those situations. So, you know, once someone is in a position, if it's in that same episode, to de-escalate, then following through with like connecting with resources to help with strengthening your rapport, and also, you know, relieve some of that stress that's causing that emotional crisis, can really be important to that person to know that you're not judging them with where they're at. And when they do have emotional crisis, behavioral acting out. I have my references, and then any questions.
Thank you, Simone. Could you turn your slideshow off so everybody can see each other? There we go. So I think that one of the takeaways for me always in these things is just where you're at in relation to the whole thing, and like where like the checking your ego at the door piece, and then also just kind of being aware of your own escalation, I think has always been the part that has been helpful to me. And once you can get that into check and sort of not make it about you, then actually it's like this kind of leap of faith and things get a lot easier. We're quiet group today.
That's because I threw so much at them.
I know. I think
Sorry.
would it be helpful if people like could think of a scenario where somebody escalated and sort of like give that as a sort of an example, and maybe we can talk through it. Has anybody been in that situation? I feel here at the clinic we've had more of this, since COVID and since George Floyd's murder. We've had more incidents where patients have escalated and staff has escalated back sometimes. So if anybody has any like instances where something happened, that could I have handled this? Could I have handled this differently? What was been a good tactic scenario? I see G waving.
Yeah, so thank you. I've got one to share, Simone. I love this. I need a copy of the slides for the staff who didn't make it on. But I remember we had a client who came in and she had a history of persistent mental illness. She had hallucinations and this kind of thing. And the backup person, so I was covering the front desk, was one of the providers. And I know that my provider has had de-escalation training specifically for this clinic. And so I was kind of looking to the provider like, hey, step in and do your thing. But also in the moment, it seemed like such an intense situation. I got a little caught up and and I snapped at the provider. I'm like, well, are we just going to stay in here like for the rest of our lives? I just like kind of lost my cool for a minute, and I had to apologize to her afterward. I'm like, you know what? You were in charge. You were the point person. I know that. I forgot it. I'm sorry, and because she's a therapist by training, she was very like, yeah, it's okay. So it's like, my point is like, even thinking we have a cool head and we know who's in charge. Like, I was really surprised how quickly I got kind of sucked in and ramped up myself just with the intensity of the situation. So that was a lesson for me, and I hope I don't repeat it.
Yeah, I think that one of the things that I've learned is that when people escalate, it's easy to match them. Like, and part of what the de-escalation, right, Simone, is bringing yourself down so they start to match you.
Yep. And it's understanding, right, where your own triggers are, right? Because we are humans. Our natural reaction is fight or flight too if we feel threatened. So being able to have some skill, pull from some strategies to observe, right? And find yourself, okay, I need to step back for a minute and observe what's going on, helps to ground you too during those times that it's easy to feel that emotional reaction with that person. So having those strategies and being able to fall back on those strategies to say, what am I seeing here? Is this a threat? Is this not a threat? It is helpful as you're moving through that de-escalation process.
Yeah, and I think really consciously being curious, like what, I try and turn on the curious part of your brain, because if you're curious and it's something about that for me, like helps with the fight or flight, like what is happening here, versus,
Or like, oh, get away or get out, because for some people they want to avoid, right? It's like, oh, out, get out, go. Because it's overwhelming. If someone comes in with that, it can be very overwhelming. So being very thoughtful and mindful, and also where you're at in that process. If you are feeling like you're getting more burnt out, are you really the point person to connect with this person who's in an emotional crisis? Really assessing where you're at and what you need to do before you even engage folks when possible. Who's a good point person for that? Because I think it's okay, when you create a team, it is okay to say, I can't do this today. Are you willing to take this take this on, because you also don't want to be a part of the cycle or the problem, and we're all human. So being mindful of that is also a part of effectively de-escalating.
Right. And I feel like when they're blaming you for whatever you did or didn't do or can't do, and you feel defensive initially, you know, so I think if we can pause and then like have a team or a plan where we can bring someone else in so that we can support each other in figuring out the plan, de-escalating the situation, but also just like, you know, staying cool and not, you know, feeling attacked is, you know, I feel like, yeah, like not matching that energy is really hard, and it takes a lot of practice. So like, yeah, I wonder, because I don't have as much interaction with, you know, offering services. I do more, well, but also I've been out in the community and I've taken complaints, you know, I've taken feedback from the community, and I've, you know, brought that back to the clinic to get it addressed. But I was able to listen and acknowledge, and also just, you know, say, you know, I'm gonna bring it back, and, you know, so, and that was actually a patient that didn't feel heard. So it wasn't directly to me, but I, you know, made her feel heard. But so I will really, you know, use the technique that you shared today. And yes, I'm going to look for the PowerPoint, because I feel like we can implement that in, you know, even in the new criteria that we're doing for the brochure that we're creating for the mothers, and when they're coming in and they're frustrated with, you know, the new baby or whatever, like we can put this in every part that, or every time we interact with the patients.
Right. And I think that having a process within the clinic where we know that we have an incident, we know we have a process where things can get escalated, you know, where we're not escalated, but where we can address concerns is also helpful. I noticed that Jace, you had a comment.
Okay, yeah. So thank you, Simone. Obviously, I wasn't able to catch the whole presentation. I was working with a client, but what I did see, I really enjoyed, and I know that I really like these sessions because our clients do get worked up, and they do get, you know, there are incidences. And what I have found is I feel like de-escalation starts way before the incident. You know what I'm saying? Like just forming those relationships with our clients and knowing that like we're probably going to run into an issue later down the road. I feel like knowing also, and I could be wrong here too, at knowing who kind of is connecting with what client, because, you know, I could be connecting with one client and I could be gone, maybe they get worked up or whatnot. And maybe they have a working relationship with somebody else in the clinic, you know, and because like, I've found that once those bonds are formed, it's easier to kind of connect with them when they are getting escalated and they're getting worked up. I feel like that's forming those relationships beforehand is really, really helpful. And what I also had to add was my first week, it wasn't like my third day, we had an incident here in the MACC clinic, and there was a couple outside and they were, you know, arguing, and there was, you know, a large presence outside. Well, I did everything that you're not supposed to do. And I went out there and I reacted and I got in the middle of it. And I learned a lot because it was interesting to be able to look back on the video and actually see all of us out there, actually just me and one other person out there getting involved. And in the heat of the moment, it's so easy to get kind of like caught up and like just kind of working on getting the client to safety and not really thinking about like looking around and observing. And that's what I learned, is kind of looking around and observing what's going on around you. And then as well as like listening to others too, like getting in the clinic when we're supposed to get in the clinic, not leaving our stations, and just thinking about the overall like safety of everybody in the clinic, you know. And what I remember too is somebody pointed out, like, we're working with adults too, you know, like if they are outside of the clinic, there's something going on, then that's kind of like their business. Like we got to worry about like what's happening inside of the clinic and like the clients that are still in the clinic. And that's one big, huge takeaway that I took from that incident though. But getting caught up in the moment can happen so easily and so fast. So, you know, listening to sessions like this is very important.
Yeah, I think it's just like anything like fire safety or any kind of training, like if running it through in your head and sort of going through the scenarios in your head beforehand, like if you can have these takeaways that can slip into place when that activation happens, it can be so helpful. I know that one of the things that came up from that incident is just that that thing of like, don't run towards the danger, you know, you know what I mean? Like, I think we're all helpers and like most of us are doing the work we're doing because we're here to help and that is our goal. And so I find myself doing that. I tend to move into situations and then I look back, I'm like, what on earth did I think I was gonna do in that situation? Like I don't, so just sort of thinking through that and like sort of creating those boundaries for yourself. It just having that thought process ahead of time, I think is very helpful. That has been for me.
I think also the communication skills. So developing, you know, because it's easy to freeze in those situations. Like, oh my gosh, I don't know what to do when it's, you know, that initial contact with someone who's in emotional crisis, right? You don't really know. A lot of times you walk in and it's like, okay, this person, you get like front desk will call, right? Oh, this person's yelling and upset. Now you're walking in, you have no idea what they're upset about. So you're thinking, you know, you got to have those go-to in that moment to start that process because it's easy to freeze as well and not go, okay, what are the steps communication wise that I need to start with or what I need to lead with? And so developing, like I said, the Dear Man model is really helpful, even in just effectively communicating with each other. So practicing that or using those tools, there's tools online, using them with your coworkers can develop just effective communication across the board. And that's huge. There's a lot of miscommunication, right? That causes people to escalate too.
Absolutely. I'm just looking through the comments. I know Julie, you had asked for a copy of the slides. If anybody else would like to have a copy of the slides, please let us know. And if you have any questions about that, also we do put these up on YouTube at these presentations on YouTube by this afternoon, right? And then and Nancy, you had a comment about being genuine, and I'm assuming with the person, if in this scenario. I think that is very important. Yeah. Any other thoughts or questions or comments, or anybody else with an experience they wanted to bring into the discussion?
Yeah, I'll iterate a little more. I just know, especially working with Native population, you know, they can see through you so well. Anybody can see through you, but the natives especially can see through you so easily. And I'm not Native, but I've worked with them for many years, and you just have to be real. You know, you just have to be. They know you're there for them, but if you're not real and you're not telling them the truth, boy, they can hit it right immediately. So just being really genuine is really important.
Thank you for that. Thank you for that comment. Just the thing that Simone said about communication, I think that the other thing is coming into a situation where you don't know what is going on can be tricky. We had an incident where a client was throwing chairs. She got very activated, but by the time that our team came to respond, she was kind of in a ball on the floor. And so the people who came into the situation assumed that she was the victim in the circumstance and brought her into a room, you know, where there was like we would not have done that had we known that she had been the one throwing the chairs, because there were sharp objects, you know, objects in the room. I mean, there was like a whole lot of other stuff going on, and so that finding a way to communicate with your team members, like when something's happening, like who the person is and what's going on is also extraordinarily important.
And taking the time, right? If that person's
Right.
on call, you have the time to kind of get some information.
Yeah. Yeah, absolutely. Okay, so we're nearing our finish time. I just want to see, Valerie, did you want to just speak to the group? You were going to reach out about a doula group? Valerie, are you on?
No camera or mic.
Oh, okay, all right. So Valerie asked if she's okay to reach out. She said she wanted to send an email for input, and she's part of a group that's working on providing substance use disorder recovery sensitive training for doulas, and wanting to know what we found most helpful or what we'd like to see, or both. That's a very interesting question. Natchez, did you want to step into that?
Sure. What about the doulas?
They're looking there. Valerie is a part of a group that is
Yeah.
that is working on providing substance use disorder or recovery sensitive training for doulas.
Oh.
And I know that, and the reason I'm asking Natchez is because Natchez is doing doula training right now. So I know maybe you guys would want to connect.
Yes, that'd be great.
Or if you had anything specific. I think that, yeah, I think that would be a great connection. Of course, I'm also happy to chat just as someone who provides OB services to patients who use substances.
Yeah, I can put my email in the chat to connect.
And I can put mine in as well.
But that was kind of what I touched on when I was speaking, was that my first thought was to put the kind of motivational interviewing skills and assessing their needs, the needs that are not being addressed right away when we meet with the mothers. So this is already kind of in my mind, so I'm glad that we're making this connection. Oops.
Thank you so much, Natchez. I think that's a great connection. Again, I'm also happy to respond. So we're gonna wrap it up for today. Thank you so much, Simone. That was a great presentation.
Everyone.
And I always enjoy that one. And we'll see you all next time. It was
Just want to remind everyone, next session is December 7th, and then we'll keep you posted on speaker and topic for that one, so stay tuned. And I'll make sure that whoever wants the slides for today's presentation receives those too. So thank you, everybody. Thank you, Simone. We'll see you next time.
Thank you. Appreciate
Bye.
you. Thanks.
Thank you.